Hello guys, welcome to AMC Prep Talks. So today we are going to do non-ST elevation acute coronary syndrome. In the previous video I have covered ST elevation MI, and in this video I am going to cover the acute management of an non-ST elevation acute coronary syndrome, which consists of an non-ST elevation MI and unstable angina. So the first line therapy in this case is also to give aspirin, first line therapy and first line management. And the very first step you do when the patient comes to you with chest pain is to give aspirin. And then we are going to assess the risk to determine need for or timing of the invasive coronary angiography. So, if the patient is very high risk and the patient at very high risk has one or more of the following, that is, the patient has hemodynamic instability. For example, the patient has dropping blood pressure or he has ongoing chest pain that is not relieving with painkillers or nitroglycerin, or there are major complications like arrhythmias, or there are ongoing symptoms with ST depression of more than 1 mm in one or more leads, plus ST elevation in AVR of E1 leads. So invasive angiography or PCI is considered within 2 hours, has to be done within 2 hours. And if the patient is high risk, if this is the very high risk, and if the patient is high risk, that is one or more of the following, that is established diagnosis of a non-ST elevation MI with increased troponins, dynamic ST segment or T waves, and Grace score is more than 140, and the symptoms are also ongoing. So we are going to do the coronary angiography within 24 hours. And if the patient is low risk, that is not high or very high risk, so we can do the invasive angiography or PCI, and make sure to do it before the patient discharges. So it is done electively. In high risk case, the PCI is done within 24 hours, and the very high risk, the PCI is done within 2 hours. Side-by-side dual antiplatelet therapy is given, that is parenteral anticoagulation. And you have to note that thrombolytic therapy is not used in the case of non-ST elevation MI. So the ultimate management here is PCI, only PCI. And on the other hand, when we were managing the ST elevation MI, if the PCI is not available, we can do thrombolysis. But in this case, non-ST elevation acute coronary syndrome, thrombolytic therapy is not used. So with the PCI, dual antiplatelet therapy is given, and parenteral anticoagulation is given. When immediate access to cardiac catheterization is not available, we can use GP2B3A inhibitors. Example, eptifibatide and tirofiban may be used with a specialist consultation. So instead of thrombolytic therapy, we can use these drugs to manage the non-ST elevation MI. So whether it is non-ST elevation MI or unstable angina, so this is the management. Now we have the recurrent pain in acute coronary syndrome. So recurrent pain that is refractory to medical treatment is called as recurrent pain, and it can signify the reinfarction with recurrent ST elevation, and then urgent coronary angiography and revascularization is indicated. Reinfarction with non-ST elevation acute coronary syndrome, and in this case there is also urgent angiography or revascularization indicated. Recurrent episodes, if the patient is having recurrent episodes, glycerol trinitrate infusion can also be given. And for patients who are already taking beta blocker, verapamil, diltiazem for angina, we can maximize the dose of glycerol trinitrate. So this is the management of non-ST elevation MI. There is also one thing I have to mention, There is a fourth universal definition of MI that is written in ETG guidelines, and it is actually MI is actually replaced with acute coronary occlusion myocardial infarction, and it highlights the ECG patterns other than ST elevation, and these can be hyperacute T waves, ST depression, and ST elevation in non-contiguous leads. So this is the fourth universal definition of MI. Another important thing, there is a question in a blue book about the most important reversible factor for coronary artery disease, for stroke. So for coronary artery disease, the most important reversible factor is hypercholesterolemia, and you have to manage the hypercholesterolemia. I've also mentioned other risk factors in the video. I will link this video where I covered the chest pain from John Morthar, and also you can check the ECG changes and the different ECG patterns of MI like STL, inferior MI and anterior wall MI, posterior MI. I have covered these ECG rhythms in my ECG rhythms video. You can check out that. So thank you for watching. That's it for today. If you like my videos, kindly share among your colleagues and subscribe my channel.